For today, I will be demonstrating the sensory, motor, reflexes part of the neurologic exam. I am Jeremy Lance J. Briones, a student of CIM. The sensory system is divided into superficial, deep, and combined cortical or discriminative sensation. For the superficial sensations, we will test for pain and light touch. Pain is transmitted by your lateral spinothalamic tract, and the light touch is transmitted by your anterior spinothalamic tract and dorsal column medial lemniscal pathway. For the deep sensations, we will test for vibration and proprioception, both of which are transmitted by your dorsal column medial lemniscal pathway. And for the combined cortical or discriminative sensation, we will test for stereognosis, graphesthesia, and point or tactile localization. Let's enumerate first the guidelines or tips for sensory examination. Number 1, you start with a superficial sensation, then to deep, and lastly, combined cortical. If there is an impairment of superficial sensation, some impairment of the more discriminative sensation will also be noted and is a contraindication to further testing. Number 2, compare symmetric areas on the two sides of the body. 3, it is typically performed in a distal to proximal direction. Number 4, not necessary to test every segment of each dermatome, but test general body areas and scatter stimuli to sample most of the dermatomes and major peripheral nerves. According to Bates, one suggested pattern is to include both shoulders, C4, the inner and outer aspect of the forearms, C6 and T1, the thumbs and little fingers, C6 and C8, the fronts of both thighs, L2, the medial and lateral aspect of both legs, L4 and L5, the little toes, S1, the medial aspect of each buttocks, S3. Number 5. Map out the boundaries of areas with sensory impairment. Start at the area of sensory impairment, then in progressive steps until the patient reports a normal sensation. Number 6. Explain and demonstrate the procedure and ask how you would like the patient to respond. And lastly, the patient's eyes should be closed in the actual testing. To test pain perception, what you need is a broken cotton swab, a reshaped paper clip, or if you have a neurohammer, you can use the sharp and dull ends of your neurohammer. Apply a uniform pressure that is enough to deflect the skin but not puncture it. And as for the response, you ask the patient if he feels sharp or dull.
Karon mag-test ko sa imong sensation. So, atong i-test kung maka-feel pa ka kung may hait o dili hait o gamay nga hikap. Sige, una ta sa hait o dili hait. So, sir, mao ni ang hait. Na, mo sa ni ang dili hait. Na, okay ra. Liyong ta. Hait. Kasra. Diinta. Iyan na lang. Relax sa atin.
For light touch, what you need is a cotton, a tissue, or you can use the brush of your neurohammer. So, touch the skin lightly, avoiding pressure, and avoid testing callous skin because these are normally relatively insensitive. Then, ask the patient to respond whenever a stimulus is felt. For this part of the test, we can incorporate point or tactile localization, which determines the ability to localize touch sensations on the skin or topognosis. So after applying the stimulus, you ask the patient to open both of his eyes and then point to the place touched.
Sir, kay akong i-test kung maka-feel ka nga gamay ng hikap or hinay ng hikap. So, imong buhaton kung maka-feel ka ikaw imong kaunaa. Kunya, di ka human, mo mata ka, itudlo nimo kung asa nimo na feel. Okay? Mo ni imong ma-feel, sir. Ayos sabi yung mata sa. Okay? Sige. Iyong ka, sir. Iyong. 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 Iyong.
Thus, for vibration sense, what you need is a low pitch tuning fork of 128 Hz. Strike the heel of your hand and place it firmly on the DIP of the fingers for the upper extremity and the IP of the big toe for the lower extremity. If you need a non-vibratory stimuli, touch the tuning fork after striking it with your hand. And for the response, ask the patient if he feels vibrating or non-vibrating. If vibration sense is intact on the distal parts, we can safely assume that the proximal parts are also intact. If impaired, you proceed to a more proximal bony prominence such as your wrist, your elbow, your clavicle, your spinous process, your medial malleolus, the shin, your patella, and your anterior superior iliac spine.
Okay. Atong i-test kung maka-feel ba ka og vibration. So, kanisi ako dapat sa imong tudlo o sa imong tudlo sa tiil. Nya, imong isulti ra kay nag-vibrate o wala nag-vibrate. Mao ni ang concern, mao ni ang vibrate. Ipapil sa nang kanimo ha. Vibrate. Yang dili vibrate kay wala kay ma-feel or pressure siya.
For proprioception, grasp the finger and the big toe at the sides between your thumb and your index finger. You pull it away from the other digits to avoid extraneous tactile stimuli and move it up and down. Ask the patient if it's up or down. If impaired, you proceed to a more proximal
Sir,
joint.
kay atong i-test kung makapil ba ka sa position sa imong joint, kung taas ba siya or naog ba siya. Mo ni ang taas, sir. Na. Yan mo ni ang naog. Okay, ito yung
For stereognosis, you need small familiar objects such as keys, coin, paperclip, and cotton. Place it on the patient's hands and let him identify it. Normally, they can identify it correctly within 5 seconds.
Nako ihatag nimo nga mga gagmay na butang niya ako ipatagan nimo sa siya. Ha? Iyong ka. Okay. Next.
If the patient has a condition that prevents him from manipulating an object, for example arthritis, or if he is paralyzed, you can test graphesthesia. With the use of a blunt end of a pencil or pen, draw a large number on the patient's palm and let him identify it.
Sir, nako isuwat sa imong kamot kanya. Isulti ko kung sa siya nga number na. Kanya, mo ni ang taas, mo ni ubos. So, kung suwat kong number 1, ana. Okay. Number 2, na. Okay, sige piyong.
3 7 5
For the motor system, we need to observe the patient's body position during movement and at rest. So note for any deformities and asymmetries. Check for involuntary movements such as tics, chorea, tremors, and fasciculations. Also check for signs of muscle atrophy and wasting. So atrophy is usually evident on the patient's shoulders, the hands, the anterior thigh, and your legs. For the shoulders, in patients with hemiplegia have atrophy in their deltoid muscle. So the atrophy will produce a sulco sign here because of the gravity pulling the humerus downwards. And for the hands, the spaces between your metacarpals should be full or slightly depressed. This is where your dorsal interosseous muscle lie. And for the thenar and hypothenar eminences, it should be full and convex.
Next is muscle tone. To assess muscle tone, you need to perform passive motion testing. So you just flex and extend the patient's fingers, the wrist, the elbow, and the shoulders for the upper extremity. And for the lower extremity, the ankles and the knees. So, sir, mag-assess ko sa imong tone karon. So, akong ipabuhat nimo is relax lang ka. Nya, sugod ta sa kamot, nya tiil. Hindi. Ibutang na imong kamot. Yes. Tiil ka, sir. Okay, ramigda. Butang lang, sir, ha? Yes. If you note hypotonia, the limbs feel unresponsive and heavy. So to confirm, hold the forearm of the patient and then move it back and forth. Normally, the hand moves freely but not completely floppy. On the other hand, hypertonic limb feels stiff and resistant to movement. So let's say, for example, our patient has elbow flexor hypertonicity. So you determine if the hypertonicity is velocity dependent, which denotes spasticity, or if it's all throughout the range of motion, which denotes rigidity. Then you can grade it using the modified Ashworth scale. For the muscle strength, we need to use manual muscle testing. So you just ask the patient to actively resist your movement. So, sir, mag-test ko sa imong kusog karon. Una ta sa kamot niya, paa na sunod. Sige. Una kay pick a imong elbow. Straight. Kumo. Nya pasaka ka, ako panao. Play, ilagyo ang mga tudlo. Ayaw ihikuan na kay pada. Okay. Sunod kay imong thumb i-hikap sa imong tudlo nga gamay nga tudlo ana. Okay. Okay, balik balik. Okay, go. Okay. Ikasta. Pika. Straight. Okay, kumo. Yan, saka. Ablihi. Ilagyo. Katong anak. Isa. Kumuta akong kamot. Because, here you go. Tidak ka, sir. Isa ka imong paa pataas. Pikas. Okay. Sunod. i-push akong kamot pa down. Gas. Pasud. Pagawas. Ikot ta sa tuhod. Go. Okay. Straight ang tuhod. Patid. Tigas. Tiko, tuhod. Patid. Sige. Pull up. Ganun. Sige. Push down. Balik. Pull up. Push down. If the muscles are too weak to contract, you test it for grade 3, which is active movement against gravity without resistance, or grade 2, which is active movement without resistance, gravity eliminated position. Sige sir, pick ka imuhang elbow. Sige, try daw piko. Try tao. Sige, try daw sir, piko. Rasad. If the patient fails to move the body part, you observe or palpate for muscle contraction. Sige sir, try tao piko sa imong elbow. Sir, okay ra ato isang kagamay imong kuan t-shirt. Lightly and briskly stroke each side of the abdomen, above and below the umbilicus. Check for abdominal muscle contractions or movements of your umbilicus.
Superficial plantar reflex. Stroke the lateral aspect of the sole from the heel to the ball of the big toe, forming a reverse J. Normal response is plantar flexion. If the response is dorsiflexion with fanning of the lateral foretoes, it is a positive Babinski sign, indicative of upper motor neuron lesion. Deep tendon reflexes. For this test, we need a reflex hammer. The smaller end is for smaller areas, such as when striking your finger during the biceps reflex. The bigger end is for bigger areas. Encourage the patient to relax, and as you strike, your wrist should be relaxed and the strike should be quick and direct.
Sir, karon mag-test ko sa imong tendon reflexes. Anya, akong ipabuhat mo kay relax lang ka, ha?
You can avoid awkward positions like this if we use a higher bed or plinth, or do the test in a long sitting or supine position. Clonus. If a patient's reflexes seems to be hyperactive, elicit ankle clonus by sharply dorsiflexing the foot and maintain it in dorsiflexion. Rhythmic oscillation between dorsiflexion and plantar flexion is positive for ankle clonus, indicative of upper motor neuron lesion. And lastly, the gait assessment. The simplest way to assess for gait is to let the patient walk across the room or down the hall, then turn and come back. Check for posture, balance, swinging of the arms, and movements of the leg. Observe also for gait abnormalities. Normally, balance is intact, the arms would swing symmetrically at the sides, and the turns are smooth.